if you want to scroll. These are just some pictures of how to do self-skin exams. And for those of you who picked up the skin cancer handout in the back, these same pictures are in there. But I'll also show you a website which has all these pictures as well. Okay, well, treatments. There are a variety of different treatments. We break them down generally into medical treatment or surgical-based treatments. And these are treatments for either precancers or for skin cancer. Medically wise, there are a number of different creams that can be used, oral medications, radiation, chemotherapy, and changing your current transplant medications. As far as medications, oftentimes in my transplant patients, in order to treat the precancers and eliminate them, because again, about 1% or up to 1% can turn into a skin cancer like squamous cell carcinoma, I'll use something called 5-fluorouracil, which is either Efudex or Carac, and you can think of this as topical chemotherapy for the skin. And what happens, if you go to the next slide, is that the areas of abnormal skin will light up like a Christmas tree. Now, this isn't a treatment for everyone. It does have side effects: redness, scaling, swelling, burning pain. But the benefit is before, during, and after is about 3 out of every 4 precancers is generally eliminated. And so you'll have a short period, around 4 or 5 years, where you have significantly fewer precancers. And the idea is if you eliminate the precancers, much less chance of developing a skin cancer. There's another medication called Aldera that's a little bit new. It works by a different mechanism. Instead of acting like chemotherapy, it actually stimulates your own immune system to develop this, to eliminate the skin cancer or precancer. We always worry in transplant patients about medications that alter the immune system because our greatest fear, of course, is causing some form of rejection. It has been studied in transplant patients. It seems to be safe. I will often start out with the chemotherapy first before I go to Aldera. I just wanted you to be aware that there are more than one agent out there. It has a lot of the same side effect profiles in terms of itchy, redness, swelling, and irritation. Of course, you would expect this if you're stimulating your own immune system to attack abnormal parts of your skin. Now, there is an oral medication that we sometimes use as a rescue agent in transplant patients with significant amounts of skin cancer called acitretin. I only mention it today because if people have a history of significant numbers of skin cancer, what we call catastrophic skin cancer, or transplant patients with skin cancer, we will sometimes use this medication in order to treat the ones that are there, prevent new ones from developing. This is only a temporary medication. Once you stop it, most people will generally go back to the same rate of skin cancers as they had beforehand. Okay, now this is something which we've recognized more in the past few years, and this is in regards to altering or changing the immunosuppressive regimen. And of course, we have to weigh changing your immunosuppression regimen with the possibility of graft rejection. So we typically will only do this in serious cases. For instance, patients who have had metastatic skin cancer, patients who generate many skin cancers, or even in a patient with Kaposi sarcoma. There are different transplant medications that seem associated with skin cancer development. Of course, this isn't true of every patient, but in general, the literature suggests Neoral or Imuran, Neoral, also known as cyclosporin, are some of the ones that are more predisposed for developing skin cancer. The length of time in which you've been on these medications seems to be important, as well as the duration, the dosing as well. There are also other transplant medications that actually may reduce your risk for skin cancer. For instance, one called Rapamune. In general, our goal is always to reduce the medications that you need to the least amount required to keep your graft healthy. Okay, let's talk a little bit about the surgical treatments. We use liquid nitrogen, very common to treat precancers, and there are a variety of different surgical or procedural ways of treating precancers and skin cancers. Liquid nitrogen, again, is the most common. We often apply it with a spray gun, and essentially what we're doing is we're doing a cold burn or a frostbite in order to kill these areas of abnormal skin. This is often the device that I use, and the treated skin will look like this for a short time, and then afterwards you'll develop a small blister or a small scab, the skin will go from what was before a scaly skin lesion to generally a newly healing skin that doesn't have the scale anymore. There are other treatments like curettage and electrodesiccation. This is a way of scraping off skin cancers, and I'm showing you a picture of an example here. There's a new treatment called photodynamic therapy, and this is using a topical drug. Sometimes in the past we used to use an oral drug, but it's a photosensitizer that builds up in the precancers or sometimes even in early skin cancers, and then you're exposed to this light, and this is an example of a patient being treated, which causes this photosensitizer to produce these forms of oxygen that can kill and destroy either early, very superficial cancers or even precancers. If you do have a skin cancer, often they are treated with surgical excision. Essentially what we do is remove an area of skin with a small margin of normal skin. The site is closed with stitches. We send the tumor that we've removed out to the lab to make sure it's completely removed. And this is typically used for non-aggressive tumors or low-risk anatomical sites. When there are sites that are more important, for instance, on the nose, the ears, the eyelids, areas that are sometimes at elevated risk for metastasis, we'll often use something called Mohs surgery. This is a particular type of surgery that's done by dermatologic surgeons. This has the highest cure rate for skin cancers. It removes the least amount of normal skin. In many cases, this is the treatment of choice for skin cancers in these high-risk areas. Okay, I just want to spend one more moment on the immunosuppressive medications because that's often a concern. There are a whole variety of different medications that are used to prevent rejection. Now, these are extremely important medications. Without them, the transplant is certainly at much higher risk for rejection. These are life-sustaining and organ-sustaining medications. Certainly, they can have their side effects, such as infection, and can increase your risk of different cancers, including skin cancer, lymphoma, or possibly cervical cancer. We mentioned the duration, intensity, and type of immunosuppression is important. For skin cancer, Neoral and Imuran tend to be the ones associated with the highest risk of skin cancer. Again, this doesn't mean you need to run out to your transplant team and tell them, I need to stop these medications. Not everyone has problems with these medications. There are other ones that are a little bit more in the intermediate. And there's a new medication which came out in the past 5 years called Rapamune. And this actually has the lowest rate associated with skin cancer. In fact, there have been a number of studies which have looked at this in transplant patients, particularly kidney transplant patients. And the risk of developing skin cancer was lower in all patients treated with this immunosuppressant. In fact, another larger study that was performed in 2005 looked at 33,000 kidney transplant recipients and found that the risk of developing any type of cancer was lower with this medication. Now, does this mean you need to go out and change your immunosuppression regimen? No. The Neoral and Imuran data with regards to skin cancer are suggestive. It's by no means conclusive. Not all patients are at elevated risk. Again, a healthy graft is our primary consideration. Rapamune is certainly an interesting medication. It's new. It has many potential side effects. It is not tolerated by everyone. The long-term side effects are not known since it's a relatively new medication, but simply the reason I bring it up is if you have a history of significant skin cancer, you're a transplant patient, this is something you may want to discuss on a case-by-case basis with your transplant team. Okay, we can move on. What are the resources available to transplant patients? At UCSF, where I trained, I actually helped start a high-risk skin cancer clinic, and its primary goal is to treat, prevent, and educate transplant patients on skin cancer. And there's how to reach these people. I'm certainly available, but the main take-home message of today is if you have a transplant or pre-transplant, get involved with your local dermatologist, make sure you get your skin cancer checked, your baseline skin examination, and if you have a history of skin cancer, you see your dermatologist more frequently. At UCSF, I also developed a website for transplant patients exclusively. And it contains all the information that I talked about today. And the reason why we generated this website is simply because there's a lot out there on the internet. You don't know what to look for. You don't know what to trust. So we generated this specifically for not only the general population, but an entire section for transplant patients. Sometimes medical professionals, as far as taking care of the skin, need a little reminder, and it also includes material for medical professionals who take care of transplant patients. In fact, since we have an internet connection here, I'm just going to show you what it looks like and where to go. So this is a website itself. It's part of UCSF. It's called the Skin Cancer Guide, the same website as we mentioned. You can see on the left-hand side there are a variety of different subjects. Skin Cancer Guide. This is just for general patients. A transplant patient guide, this is for you. And then caring for transplant patients, this would be for medical professionals. If you click on the transplant patient, it mentions all the same information that we talked about. It goes over risk factors, types of cancer, immunosuppression, prevention, follow-up, medical treatments, surgical treatments, all of the things that we just talked about. And this is available to you or to anyone to look at 24 hours a day. There are ongoing studies. UCSF is pioneering some of these. If you want to get involved in why transplant patients get more skin cancer, you can certainly get involved in the study at UCSF. This is one of my colleagues up there. If you'd like to be involved, you can certainly contact her, and she can get you enrolled in this study. So the phone number, if you want to go back, is Debbie 415-353-7989. This is at UCSF. Okay. In addition, any of you who picked up a Sun Protections clothing catalog, there's a survey inside this. Sun Precautions is doing a study in identifying sun protective clothing and use in transplants. And so any of you who return a completed survey, there's a self-addressed mail-in envelope with each study. Will actually get automatically entered into a free drawing for free sun protective clothing, and there will be 10 winners. Okay, so in quick summary with regards to the skin cancer is that all transplant patients are at higher risk. Squamous cell carcinoma is the most common skin cancer. Transplant patients, pre-transplant patients need to see their dermatologist. We can detect most skin cancers and treat them if they're detected early enough. What is the risk factor that you can modify? Typically, sun exposure. We talked about a lot of different strategies for limiting your sun exposure. Okay. Now, before, when I talked to Linda, the steering committee had also given me a list of questions pertaining to some of the kidney transplant or pre-transplant patients, and I wanted to address those before we open up to a question and answer. So, if we go back to that real quick. In particular, itch, shingles, how often do I need to see a dermatologist? I think I've tried to address that last question already. There are also some questions about cold sensitivity, skin darkening, and skin diseases with kidney disease. I wasn't quite sure exactly what these meant, so if someone wanted to clarify during the Q&A, I'd be happy to address those specifically. But let's spend a moment on itch. Now, how many of you have noticed this? Can I get a show of hands? Okay, so itch is the most annoying thing in the world, isn't it? And there are a couple ways that when I see a patient, I think about itch. I think of the common things common, and then there are specific things that happen in kidney transplant patients. So the common things being common, dry skin. Patients, or renal patients, all have a problem with dry skin. We don't know exactly why, but we'll talk about strategies to treat dry skin. Dry skin can be the cause of itch or can make any other disorder even worse, or make itch caused by other disorders even worse. Now, what's an itch associated with kidney transplant or with patients undergoing dialysis or with kidney dysfunction, often referred to as uremic itch? This is an itch caused by the buildup of toxins, and sometimes from nerve damage from the uremic neuropathy, which will cause itch in patients, particularly patients in dialysis. In chronic renal failure without dialysis, around 15 to 50% of patients will have chronic itching. They won't see a rash, they'll just feel itchy. Dialysis, this number goes up to 59% of patients. Very annoying. Sometimes this will resolve and typically resolve with the kidney transplant. And there are a number of different studies, ways of treating itch that have been studied, including topical therapy, oral drugs, intravenous medications, physical treatments, homeopathic remedies, and all of them have some rates of success. I will talk about some of them today. So first of all, common things common, how do you treat dry skin? So the moisturize, 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 correct. So the way you treat dry skin is moisturize it. But there are certain things you need to know and that are helpful hints about how to moisturize. So it turns out there's a paradigm of what moisturizes your skin better and what doesn't work that well. Ointments, creams, lotions. Ointments are the best and they're the strongest. Lotions are the weakest and generally work only temporarily. But what's wrong with ointments and why don't people use them more frequently? They're greasy. They don't feel that good. They're hard to get used to. But boy, do they work well. Lotions, they feel well. They're the things that will come in a pump that you can go buy at any drugstore. They work well for around 20 minutes, but after the water, and these are water-based treatments, after that evaporates, your skin goes right back to being what it was. Good ointments that I like to use include Aquaphor or Vaseline. Good creams. Now, creams are a good intermediate. They're a little greasy. They're not too greasy. They stay in your skin a lot longer than lotions. I will often recommend use for them to my patients. It's over the counter. It's very inexpensive and something that I would recommend you using frequently. My rule of thumb, if it comes in a pump, it's not good enough. Everything that comes in a pump is generally a lotion. Moisturizing, even in the absence of itch, may be preventative. So if your itch is treated with moisturizing, just keep on doing it. Now, habits that can cause dry skin will make itch worse. Hot showers, long hot showers can often exacerbate itch, particularly when your skin dries. So I generally recommend lukewarm showers lasting less than 15 minutes. Drying soaps. Now, soaps vary in intensity. Some are very good and very strong. For instance, Ivory is a fantastic soap, but very drying. Lever 2000, fantastic soap, very drying. I tend to recommend non-drying soaps like Dove or Cetaphil. You avoid soap in the itchy areas, so if it's your arms, your legs that are itchy, unless they're really dirty, don't use soaps in those areas, just use water. Once out of the shower, one way to make these moisturizers more effective is blot dry and immediately apply your moisturizers on top of damp skin. That will tend to lock in that moisture and keep your skin better hydrated. Over-the-counter medications that can help counteract itch. Well, we know that itch is worse with heat. So stay cool. Avoid the hot baths or showers, as we mentioned. Now, you can also get immediate and short-term itch relief with an over-the-counter medication called Sarna. There are a number of different over-the-counter medications which have menthol. Sarna Aveeno Skin Relief Moisturizing Lotion, Eucerin Anti-Itch Moisturizing Spray. Sarna is usually available at every drugstore. Looks like this and can certainly be purchased, and we use it a lot in our renal patients with just chronic itch. Again, it is a short-term treatment, is not a long-term treatment, but can provide good short-term relief. It does have a little bit of a medicated smell, though. Okay. Other common uremic itch treatments. Well, sometimes in rare cases, we'll use anesthetic-type creams like Pramisome or lidocaine gel patches. These are prescription. You'll need to get a prescription from a dermatologist or your doctor. One of the more common ways to treat itch are with antihistamines, either ones applied to the skin like Benadryl cream, Zonulon, which is prescription, orally Benadryl or hydroxyzine are sometimes used. Hydroxyzine, also known as Atarax, is a prescription medication. Typically, we'll use the antihistamines before bedtime because they can cause sleepiness. Always make sure you check with your renal doctor to make sure that these are safe for you. Another cream that we'll sometimes use is something called capsaicin. This is over the counter, so you can purchase it at any drugstore. This is an all-natural substance made from peppers, but because it's made from peppers, it will burn when you first use it. It uses that same substance that gives you the spicy sensation in your mouth, but when used over a regular period, 3 or 4 times a day, in some patients, they will get a very good resolution of the itch. But in my experience, because of the burning sensation, because you have to use it very frequently, it's only tolerated in only a small numbers of patients. There are anti-inflammatory creams, hydrocortisone, other stronger cortisone-based medications, or non-cortisone inflammatory creams like tacrolimus, These really only have a limited basis in treating uremic itch because the condition isn't inflammatory. It's due to the mediators that we talked about before. Now, if you're having chronic itch, make sure you talk about it with your dialysis doctor if you're on dialysis, because the dialysis settings can sometimes be adjusted to decrease the itch. If your renal doctor doesn't know that you're having the problem, he's certainly not going to make any adjustments. One external form of treatment that we often use is something called UV light therapy. And this is an example of what a UV light chamber looks like. This is very effective for uremic itch, but we don't use it for patients with skin cancer because you are being exposed to certain types of UV light. But if you're at low risk for skin cancer, have few risk factors, then the treatment can be very effective. But it is a little bit of a time sink. It is a 3-day-a-week treatment. But eventually, as you get used to the treatment, and if the treatment is effective for you, it can be used less frequently, even up to once a week. A newer medication that's being used, and this is more still in the study phase, is something called gabapentin. This has been used in some patients and seems to be also useful for uremic itch. It's an oral medication that's typically taken after your hemodialysis. The most common side effect is that it causes a lot of fatigue and sleepiness, but in the studies that have been done, it certainly seems like it may be a very useful agent in the future, but again, something that needs to be discussed not only with your dermatologist, but with the kidney doctor. And typically we reserve this for people who have failed all the other treatments that we talked about. Okay, one other question from the steering committee was shingles and shingles vaccine. In particular, do transplant patients get higher incidence of shingles? And the answer is absolutely. Shingles is a painful skin rash that often is associated with blisters. It's also known as herpes zoster. Usually, in the hallmark of a shingles rash is it occurs only on one side of the body, and it has these blisters. You want to just click. And this is an example of a patient with herpes zoster or shingles on one side of the body. The main symptom is usually pain, which is itching and burning. 1 in 5 patients can also have severe pain that continues even after the rash clears up, called post-herpetic neuralgia. A close-up of what these look like are these little blisters that occur in group clusters. The risk for shingles is certainly elevated in transplant patients, typically because of the anti-rejection medications. Now, there is a shingles vaccine. The FDA has licensed its use for people over 60 years old to prevent shingles. It's a one-time immunization. In studies, it seems to reduce the chances of getting shingles by 51% and reduce the risk of post-herpetic neuralgia by around 67%. Now, is this for you? Right now, in transplant patients, because of the immunosuppression, it's typically not recommended, but certainly can be discussed on an individual basis with your transplant team. Why? This is a live vaccine, so it is an active virus. And so, in general, well, we'll get to that in the next slide. If you go to the next slide. In general, we don't recommend it in people with immunosuppression. But in people who haven't had their transplant yet, so pre-transplant patients, no matter what age, I certainly would discuss obtaining this vaccine with your transplant team or your renal doctor because it can be very useful at preventing shingles after you have received your transplant and are on the medications.